Hi, so today we have a case of 73-year female patient with a cervical mass, and the patient presented with postmenopausal bleeding. We have a section from that cervix. So with it, we can see a tumor in variably infiltrating into the stroma. Now, if we zoom in into the tumor particularly, then we can see different morphological pattern at different areas. So here we can see some papillaries area, and then there are some cribriform areas, the tubular areas. There are some also short glandular pattern as we can move around. There are cribriform areas also, and in this part of the tumor we can see some solid areas with high grade nuclear feature. The nuclei become more basophilic in appearance. In other part of the tumor we can have this kind of very appearance that gives a clue that of our six cord stromal differentiation over here. Now if we move around, we can see the tumor is having the similar kind of morphology that we have already depicted, that six stromal like differentiation, as well as some papillary areas, glandular areas, and tubular areas also. Now if we move in, and we can see this all the tubular lumen, they have some characteristic eosinophilic globules in few of them, like they are prominent in the higher magnification. And in this magnification also we can see the nuclear details of the tumor, that they are of variable pleomorphism. They show variable degree of mitosis, and at places we can see some nuclear grouping also. So keeping all this mind, the varied or myriad nuclear feature, the architectural pattern, we can suggest the possibility of mesonephric carcinoma of cervix. Okay, now if the similar scenario that happens within in this picture happens to be in the endometrium, and that are arising from the endometrial level, you can suggest the possibility of endo this is your mesonephric like adenocarcinoma, because you know that mesonephric adenocarcinoma, they are said to be derived from the mesonephric remnant. Okay, now if you get this picture in the endometrium, then you can say that it is a mesonephric like adenocarcinoma. And if it is arising from the lateral wall of the uterus or at the parametrium, then you can suggest a possibility of mesonephric adenocarcinoma of uterus, because you know, if you follow the embryological development, the mesonephric remnant, they resides at maybe near the adnexa, the parametrium, and in the cervix. So anywhere you get this mass that is arising or located in that zone, then you can suggest a mesonephric adenocarcinoma. And if it is arising from the endometrium, then it should be a mesonephric like adenocarcinoma. Mind the difference, because you know that molecularly they can show the similar KRAS mutation. That is one thing. And sometime the PIK3CA mutation and PTEN mutation, they help to differentiate between the MLA, that is mesonephric like adenocarcinoma, from mesonephric adenocarcinoma, because mesonephric adenocarcinoma, they lack PIK3CA and PTEN mutation or ADITA mutation. Okay, that is one part from the molecular aspect. And immunohistochemistry, they suggest some red flag that whether they are mesonephric carcinoma or mesonephric like adenocarcinoma, because both are morphologically and immunohistochemically similar. They have WT1 negative, and estrogen usually negative, and PR is universally negative. Okay, and now coming to the other picture, other immunohistochemistry that can be positive, like it should be positive for your TTF1, KETA3, CD10 is a good marker for mesonephric origin, so that becomes a positive and good marker for differentiating endometrioid or low grade endometrioid carcinoma from the mesonephric carcinoma. So this is the nutshell, and in a prognosis you must say that it is the tumor that carries a poor prognosis with frequent metastasis to lung or to liver, and they have a dismal prognosis than that of a typical endometrioid carcinoma. So this is how you can differentiate these two clinical features that have a completely different prognosis depending on its histological diagnosis.